Okay, we'll get going with our next session here. So the recognition that the androgen receptor plays a role in castration-resistant prostate cancer was a major discovery that led to the development of targeted agents with reasonable tolerability. These are drugs that any urologist can utilize, but it's important to understand the mechanism, the side effects, dosing, in order to run a successful advanced prostate cancer clinic. So these drugs essentially were developed for more advanced cancer and have been moved forward in the progression of prostate cancer. Again, as you can see on the far right, castration-resistant prostate cancer with metastatic and then non-metastatic. And a number of these drugs are now being utilized as doublet therapy in combination with androgen deprivation therapy. So several of the objectives for this lecture are to talk a little bit about mechanisms for castration-resistant prostate cancer development, to understand existing and new applications for these agents. We'll talk some about mechanisms and importantly side effects of abiraterone, enzalutamide, and the other androgen signaling inhibitors, and then talk a little bit about several new developments. So this is a typical situation where you'd use one of these drugs, a history of biochemical recurrence following radiation, patient with who was placed on androgen deprivation therapy for several years. His PSA began increasing rapidly. Importantly, testosterone was checked and found to be low. And what we see in this patient is new bony pelvic metastases and enlarged pelvic lymph nodes. So a striking finding is that over 70% of castration-resistant prostate cancer metastases exhibit robust androgen receptor expression, and realize that observation was really only made about 20 years ago. And in autopsy, you can see on the right that many of these exhibit androgen receptor amplification. Now, it's important to realize that there are ligand-independent mechanisms for castration-resistant prostate cancer, including co-activators and utilizing other types of hormones. But we're going to be focusing more on ligand-dependent mechanisms in this talk, just because the drugs that we have really target those. The increased or amplification of androgen receptor is shown in the middle here, and that is generally, if you have an increased availability of the androgen receptor, you're able to bind available ligand, and that will lead to singling. So androgen AR amplification. At the top of this slide, you see adrenal androgens. So the androgen receptor is able to become more promiscuous and bind adrenal androgens, and these can induce singling. And this is the mechanism of inhibition for abiraterone. On the left side of your slide, the androgen receptor can also develop mutations that make it more able to bind other ligands, including glucocorticoids and other metabolites. And then finally on the right, the androgen receptor can develop these variants, which can then bind also to the target and cause signaling. Again, apalutamide, darolutamide, and enzalutamide are all focused on the androgen receptor signaling at the level of the androgen receptor. So we'll start with abiraterone, and it's an irreversible inhibitor of the hydroxylase and lyase activities of CYP17A. And again, this catalyzes the conversion of C21 to C19. It's much more potent than ketoconazole, which was an early drug that many of us will remember. And it's associated with an expected increase in mineral corticoids. So by blocking the CYP17, you see an increase in aldosterone, you see salt retention, hypertension, low potassium. Furthermore, cortisol levels are also altered because of this inhibition. And in order to blunt this, these drugs are given with prednisone. These drugs were originally validated in castration-resistant prostate cancer post-chemotherapy and pre-chemotherapy, and these were some of the early trials that were done now over about 10 years ago. In addition, side effects from these drugs, it's important to be very aware of these. We talked a little bit about the hypertension, hypokalemia, but it's the liver function tests are also altered as well. So in these patients, it's important to routinely check these liver enzymes. How do we minimize the side effects associated with this? Taking it on an empty stomach, giving with prednisone, 5 milligrams, either BID or once a day. And when initiating these drugs, abiraterone, liver function tests and then electrolytes need to be checked every 2 weeks after starting. If they develop this increase transaminases, stop the drug, wait several weeks, and then you can restart at a lower dose. Finally, routine assessments for hypertension and fluid retention, and it's important to use these drugs in conjunction with the internists. And then finally, remember some drug interactions, especially with Coumadin. These levels increase because of the CYP inhibition. So in this situation, I mentioned abiraterone was really one of the first drugs to be combined with androgen deprivation therapy in metastatic hormone-sensitive prostate cancer. And that's really a situation where we as urologists will use it more frequently. So it's FDA approved for metastatic CRPC before and after chemotherapy, also with metastatic hormone-sensitive prostate cancer, and then off-label for M0 CRPC. We talked about the side effects, including hypertension, hypokalemia. So patients that are generally poor candidates for abiraterone treatment include those such as diabetics, those with ulcers or rapidly progressive disease infections. Again, they can't really tolerate the systemic steroids in that situation. Individuals who have issues with edema, heart failure, again, not an optimal candidate for abiraterone. And then finally, ongoing liver disease. So we'll talk now about androgen receptor signaling inhibitors, and the first one that was developed was enzalutamide, and this was rationally designed androgen receptor signaling inhibitor. And it's important to realize that it targets multiple steps in the pathway. It not only inhibits binding of the androgens to the androgen receptor, but it also inhibits translocation into the nucleus, as well as association of the androgen receptor with DNA. So multiple points. Apalutamide and darolutamide have similar mechanisms of actions, slightly different side effect profiles, and we'll talk a little bit more about those. So enzalutamide, again, first initially demonstrated in the AFFIRM trial that it improved survival in castration-resistant prostate cancer. On the right is just showing in the pre-chemotherapy trial, you also saw inhibition or a slowing of radiographic progression in these patients. Some of the side effects that one should be aware of include fatigue, and this is especially significant for older patients. Hot flashes are also seen. One has to be careful about CNS-related side effects, and there was a slight increase in seizure activity, and then finally hypertension. Again, in these older patients, they're more susceptible to fall on these drugs as well. They're susceptible to fall anyway, but need to be aware of that. So there's certainly things to think about with regard to this. Dose reduction if the patients begin to develop, or if you're giving concurrent CYP inhibitors. Gemfibrozil is a cholesterol drug. Also be aware if they're on warfarin that it can affect the serum levels of this. If there is profound fatigue with this drug, one should consider a dose reduction. And be also aware that it does lower your seizure threshold if you're taking some other drugs such as Purion. And then finally, one can, if there are side effects associated with this, remember the half-life is about 8 to 9 days, so stopping dose and starting at a reduced dose, you'll generally have to wait a week before doing that. So enzalutamide, which patients FDA approved in metastatic castration-resistant prostate cancer before and after chemotherapy, M0 CRPC, as well as metastatic hormone-sensitive prostate cancer. The fatigue is something to consider with this drug, hypertension. It can also cause constipation or bowel-related issues, and then be aware of the CNS-related effects. And you can see here, these are generally patients that are poor candidates, elderly, fatigued individuals. Other signaling inhibitors, apalutamide, has a similar mechanism of action. These are the trials validating it for the FDA. Similar side effects in addition to hypothyroidism that's seen with this, and a rash. And then darolutamide is similar, again, a similar mechanism of action, maybe a little less in the way of CNS-related side effects because of the decreased penetration of the blood-brain barrier. So we'll be talking a little bit about this in the next talk, about which of these pathway inhibitors should go first in advanced disease. And there's really limited randomized data to choose to guide us in making this decision. Often financial issues may often dictate which of these would go first. Generally, one would avoid following one of these pathway inhibitors with another. So if one is using enzalutamide, typically apalutamide would not be a good choice. As far as sequencing, there was a trial looking at this, the CARDS trial, that suggested patients that had failed abiraterone may develop there may be some benefit with enzalutamide. Conversely, enzalutamide followed by abiraterone, very little improvement as far as PSA decreases. Again, we'll be talking more about that. Again, when you're in a situation where the disease is rapidly progressing, the pace of the disease, one needs to consider going straight to chemotherapy, docetaxel, or carboplatin-based chemotherapy. So this is looking at oral pathway inhibitors, and again, a number of these have been developed as doublet therapy for metastatic hormone-sensitive prostate cancer. You'll be hearing about triplet therapy, combining them also with chemotherapy in the next talk. So I'll spend the last 2 minutes or so just talking about adverse events with these pathway inhibitors and androgen deprivation therapy. Hot flashes can be mitigated with venlafaxine or gabapentin, are typically used for this osteoporosis. It's very important to be aware of, and there'll be a lecture on that a little bit later. Fatigue, regular exercise may be used in this to help offset this. And one we'll spend a little more time talking about is cardiovascular disease, since this is very common in elderly patients. And realize that androgen deprivation therapy does adversely affect cardiovascular disease risk factors, including serum lipoproteins, insulin sensitivity, and also obesity. And in 2010, the FDA actually included new safety information for a number of these GnRH agonists, warning of increased risk, cardiac risks. There have been a number of meta-analyses that have reported associations between ADT and greater risk for cardiovascular events. And these are fairly consistent with the GnRH agonists, mixed associations with the antagonists, the newer antagonists that are being used. And there was one trial, the HERO trial, where there was an increased risk of major cardiac events with leuprolide compared to the antagonist, GnRH antagonist, Relugolux. But in contrast, their following studies and pooled data have not really demonstrated a big difference as far as cardiovascular toxicity with GnRH agonists and antagonists. As far as cardiovascular assessments, we don't do this very well. In a study several years ago, it was over 30% of patients didn't get a comprehensive cardiovascular assessment prior to initiating ADT. So one needs to think about risk, looking at blood pressure, lipids, blood glucose, and again, this is in our guidelines now, so it's important to be aware of this. And now finally, I'll just mention a trial. We traditionally have always thought of estrogens or DES as something that was only used historically, but more recently it's being delivered as a patch, and this avoids some of the liver metabolism that created issues previously. And one can see that hot flashes are markedly reduced with these estrogen patches. Gynecomastia is, however, a major issue, and the risk of cardiovascular event is low as well. So transdermal estrogen is another option as a patch for patients in this situation. So as far as our take-home points, the combination of androgen deprivation therapy and these androgen receptor signaling inhibitors, plus or minus docetaxel, are now standard of care in patients with metastatic hormone-sensitive prostate cancer. Realize that enzalutamide, apalutamide, and darolutamide are androgen receptor signaling inhibitors. They're preferred in patients who can't tolerate systemic steroids, these brittle diabetics. Abiraterone, on the other hand, is an androgen synthesis inhibitor, a CYP1720 inhibitor, and that may be utilized more in these patients that are elderly with profound fatigue or seizure history. And finally, when initiating androgen deprivation therapy, one must consider the potential side effects and cardiovascular evaluation for those individuals.